Welcome to the deep dive. So today we're tackling a really fundamental problem in modern healthcare. It's this idea that hyperspecialization can sometimes, hurt the patient more than it helps.
Exactly.
And we're going to do that by looking at this huge case study out of Northeast Ohio, the University Hospital's Harrington Heart and Vascular Institute. Let's call it HHVI.
And this is such a critical topic. I mean, the sheer vascular burden, we're talking diseases of the arteries, veins, the lymphatic system. It is just enormous.
Give us a sense of the scale.
Okay, so you're looking at maybe 8 to 10 million people in the U.S. alone with peripheral artery disease. And on top of that, nearly 1 million new diagnoses of venous thromboembolic disease.
Every single year.
Wow. And the sort of traditional way to handle that is to just divide and conquer, right?
You get vascular medicine, vascular surgery, interventional cardiology, radiology, podiatry, all these crucial specialties.
But they're all operating in their own little world. Our sources kept using this phrase, siloed and contentious. Yes, that really sums it up. It felt like the system was built around the needs of the specialty, not the actual patient's journey through their illness.
So our mission today is to really get into this UH initiative, which kicked off in late 2017, to see how they moved from that contentious model to something unified and truly patient-centric.
It's a fascinating story.
Okay, so let's start there. Before 2017, paint a picture for us. What did that fragmentation actually look like on the ground at university hospitals?
Well, it was a system that basically reflected their huge physical footprint, 23 hospitals.
So care was all over the place.
Completely. The quality of care you got, the access you had, it really just depended on which individual doctor you saw and, frankly, your zip code.
If you lived near the best surgeon, you were lucky. If not,
tough luck. Physicians were kind of in these separate fiefdoms. They managed their own patients, and there just wasn't much system-wide thinking.
I have to imagine that in an emergency, that kind of fragmentation could be, well, dangerous.
Oh, it created huge bottlenecks. For acute cases, vascular surgery was sort of the catch-all for most emergency calls.
Okay.
But then you had interventional cardiologists who are often only responsible for their own patients.
So gaps in coverage were inevitable.
Big gaps. And it fostered this professional rivalry instead of collaboration, right, when every second counted.
There was one detail that I found just astonishing, considering the size of this system. It was about their non-invasive vascular medicine.
It's a perfect example of the problem. For that entire massive health system, non-invasive vascular medicine was served by just a single provider.
One person.
One person. Imagine the backlog. Imagine the lack of regional expertise. And then operationally, the waste was just immense.
Like what?
Duplication of services everywhere. No integrated supply chain. So every hospital was out there buying the same stents, the same catheters, all on their own.
So let's unpack this. The core problem wasn't just clinical. It was, at its heart, a financial and an administrative one.
That's it, exactly. All the resources, all the money, it was tied to these departmental budgets. It made working together, structurally impossible.
If interventional cardiology made money on a procedure, that money stayed with them, even if a surgeon had to clean up a complication later.
Precisely. That incentive structure. That was the first thing they had to be completely dismantled.
So how did they do it? How do you start a revolution like that? What was the new foundation they designed?
They started, smartly, with leadership. The new leadership team was interdisciplinary from day one.
Okay.
So you had 3 physician leaders, one from vascular surgery, one from vascular medicine, and one from interventional cardiology, all supported by one dedicated administrator.
You can't ask the teams to integrate if the leadership isn't.
You can't. But the real game changer here was the financial piece. You mentioned that profit and loss dashboard.
Right. How does a P&L that's agnostic to specialty even work? It sounds impossible.
Well, this is the magic bullet. They created one single financial pool for the entire vascular service line.
One bucket for everything.
Everything. All the technical revenue, so facility fees, equipment use, any payments for vascular care, it all got tracked under one P&L. It didn't matter which department's room you were in or which doctor's name was on the chart.
So that immediately kills the incentive to hoard patients or resources.
It completely changes the conversation. It's no longer my budget versus your budget. It's how do we, together, make the whole vascular center work better.
And once the money was aligned, they could focus on the clinical mission.
Exactly. That's when they built these incredible interdisciplinary programs to tackle the most complex conditions and reduce what's known as the heterogeneity of care.
Let's pause on that phrase, heterogeneity of care. What does that actually mean for a patient lying in a hospital bed?
It just means inconsistent care.
Yeah.
So you have a patient with a really complex lesion in their leg. If they see a surgeon first, they might get pushed toward an open bypass. But if they see an interventional cardiologist first, they might get a stent. Now, if both are viable options, the best path forward is usually a decision made by everyone.
Right, a consensus.
Yes. Heterogeneity means patient A gets the bypass and patient B gets the stent. Not because of what's medically best, but just because of which front door they happen to walk through.
And these new teams were designed to stop that.
They mandate consensus. Teams like the Limb Salvage Advisory Council, or LSA, the Pulmonary Embolism Response Team, PERT, and the Aortic Care Team, ACT.
And these teams were the core innovation then.
They were. Take PERT, for example, which handles life-threatening pulmonary embolisms. It's not just vascular specialists.
Who else is involved?
The leadership includes vascular medicine, pulmonary and critical care, and interventional cardiology. So the patient gets the benefit of that three-way conversation before any major decision is made.
So you have the blueprint, you have the teams, but making it stick, that requires a massive cultural shift. How did they handle things like quality review when you suddenly have different specialties, grading each other's homework?
They made everything interdisciplinary, all of it. Peer review, quality improvement, morbidity, and mortality conferences. Everything became disease-centric, not specialty-centric.
And they had a name for this philosophy, fractal learning. That sounds a little abstract.
It does, but it's actually pretty practical.
Break it down for us.
It's the idea that a mistake made anywhere in the system is a learning opportunity for the entire system.
Okay, I see.
So if a complication happens in a cath lab at a small community hospital, the review and any protocol updates have to be shared and adopted across all 23 hospitals by everyone.
It stops silos from hiding their mistakes.
Exactly. It forces a system-wide commitment to their goal of zero harm.
Okay, this is where it gets really interesting for me, the operational changes. Tell us about this ACT auto launch program. It just sounds like a total surrender of departmental autonomy.
It is. And it's a completely radical solution to a critical problem: time. Specifically, time wasted transferring really high-risk patients.
When someone shows up with an aortic emergency, every minute is crucial.
Every single minute. And normally, the doctor at the smaller hospital has to get on the phone, find the right specialist at the big academic center, and basically sell the transfer. It takes forever.
And the patient is just sitting there waiting while doctors negotiate logistics.
Yes. So the ACT auto launch mandates automatic acceptance for transfer. The patient is accepted before any discussion with a specific provider, no matter what the capacity issues seem to be.
That just removes all the friction. It's patient first, period.
It prioritizes the patient's immediate need over any departmental headache.
But that leads to the biggest hurdle in any big healthcare change, the money and the doctor's contracts. You can't just tell a bunch of high-powered specialists their compensation model is changing without a fight.
And that was, without a doubt, the single biggest administrative challenge. You had academic doctors, community doctors, independent physicians, all with different bosses and different financial incentives.
So what did they do?
A lot of talking, a lot of sharing data to prove how the old way was hurting everyone. And then, crucially, they rewrote the compensation structure, system-wide.
How do you even do that? How do you change compensation to reward collaboration?
You start tying incentives to team performance and the overall system's efficiency, not just how many procedures one doctor does. So when the big P&L showed that coordination led to better use of resources, like, say, saving money by consolidating the supply chain, everyone shared in that financial gain. Suddenly, collaboration paid better than competition.
That alignment is what makes the cultural change actually stick.
It's the engine that powers the whole thing.
So after all this structural change, this cultural rewiring, did it work? Did it actually translate into better care and better access for patients?
The results are, well, they're pretty staggering, both operationally and clinically.
Let's start with operations.
Okay. Since 2017, they've seen a 4-fold increase in the number of surgical and endovascular procedures.
A 4-fold increase. That's a massive jump in volume. But did the quality hold up?
The quality got dramatically better, and so did access. Because everyone's on the same team now, patients get scheduled with the nearest qualified provider, not just, the nearest surgeon or the nearest cardiologist.
That makes sense.
And get this, nearly 90% of their endovascular procedures are now done in cardiac cath labs.
By both cardiologists and surgeons.
Yes, which means they're using that expensive real estate way more effectively. It lowers costs, and it frees up the main operating rooms for the most complex open heart surgeries.
What about the doctors themselves? I mean, did this help with burnout? The workload must be intense.
It did. They set up a joint call schedule across 10 of the acute care hospitals, broken into 5 regional teams. It massively reduced the call burden for individual vascular surgeons. Morale went way up.
And that unified schedule means you always have coverage for the critical teams.
Right? PERT and ACT have 247 coverage because the team is covering for each other. It proves that collaboration doesn't just help the patient, it helps the provider too.
Okay, let's get to the clinical result that really, as I said, sticks with you. The outcome from the Limb Salvage Advisory Council, the LSAC.
Yeah, this is the most profound one. By mandating that a consult must happen through LSAC before any major amputation for chronic limb-threatening ischemia.
So forcing a second interdisciplinary opinion.
Forcing it, the system achieved a 75% reduction in major amputations.
75%. That is life-altering. That's not an incremental improvement.
It's a revolution. It means thousands of people are keeping their legs, keeping their mobility, all because the system forced the best possible consensus decision. It squeezed out that heterogeneity of care.
Incredible.
And it's not just that. The PERT program, which is getting close to 2,000 activations, is showing huge reductions in mortality, bleeding, and readmissions for pulmonary embolism. They've standardized quality across the board.
So this model, which they built to solve common vascular problems, is now being used for rarer conditions too.
Exactly. They've applied the same framework to create new programs for things like fibromuscular dysplasia and median arcuate ligament compression syndrome. They've become a national referral center because they can guarantee that every patient gets input from every single relevant specialist.
It's a model that it enhances everything. Patient care, doctor satisfaction, recruitment, quality outcomes. It's not about just adding more specialties. It's about engineering collaboration from the ground up, starting with the finances.
And it proves that this framework of forcing consensus through unified finances and leadership, it can absolutely be translated to other complex diseases that are stuck in those same specialty silos.
So here's the final thought. The sources make a point to say that despite all this progress, vascular care nationwide still suffers from these persistent gender, racial, and geographic disparities. So if a model like this, one, mandates interdisciplinary discussion, if it forces a second opinion before any life-altering treatment decision is made, could this kind of system-wide collaboration be the single most powerful tool we have to finally reduce that entrenched bias, the heterogeneity, and start to seriously address those critical issues of health equity? Something for you to think about.